Okay, well, I think the influx has slowed. I think now is probably a good time to start, as good as any. So welcome everybody tonight to your Seattle Now membership meeting. We are recording tonight just in case there are some folks that were unable to attend and wanted to check out this important topic later. So if you don't want to be recorded or you don't want your photograph on here, you can switch off your camera and rename yourself if you want to. If you have questions on your name, you can message me or raise your hand, and I can help you with that. So we have special guests tonight with us, Save Secular Healthcare, which is a coalition here in Washington State. I'm going to read you their tagline because I think it's pretty cool. Fighting monopolies that threaten your health and limit your treatment options. So I think that's just a nice summary of Save Secular Healthcare that Susan and Carolyn and Dennis will go into later. So I was introduced to Save Secular Healthcare, was it 2 years ago now? I guess, right after the Virginia Mason CHI Franciscan merger was announced, and our volunteer and now board member, Dennis Barnes, introduced me, and I had a really great learning session with Susan and Carolyn on the topic. So that's all I'll say right now, and we'll pass it over to Susan to do to kick off the presentation tonight. And I'm not sure if you guys want to just wait to have questions at the end or during the format, so I'll just direct you guys to how you'd like to handle that.
Yeah, I thank you very much, Amber. And I believe that for the most part, we'd like to hold questions till the end. It's so easy with this topic to end up going down one of many rabbit holes. And so we want to be sure that we're able to cover everything. Also, if you are not one of the speakers, if you could go ahead and mute yourself, that would be really terrific so that we don't pick up any background noise as we go through the session. But the title of our talk this evening is The Effects of the Ethical and Religious Directives, or the ERDs, on healthcare in Washington. And I'm going to go ahead and hand over to Carolyn to get us started.
Hello, everyone. I'm so glad to be here tonight and talk about this really important subject. And there are a lot of critical questions. And one of them is, are you really aware of how much the monopoly has overtaken our hospital care, and kids have count the monopolies. So 49% of hospital beds in our state are now controlled by healthcare systems who do not offer their patients access to all the healthcare services that are available, and maybe even more. Sometimes I hear 52%. So we're here to talk about this tonight and a lot of more information on it. This is really a question every resident of Washington must grapple with, think about, and moving forward as our access to affordable, comprehensive, and equitable services is becoming increasingly restricted.
So why do we care? What got us involved in this? We're going to take just a moment for each of us to give you a very brief introduction to ourselves and how we got into this. I'll start with myself. I'm Susan Young. I live in Bremerton, and I had dealt with a takeover of another faith-based system up in the San Juan Islands when I lived on Lopez, and people just fought it tooth and nail. I moved down to the Bremerton area and thought, phew, I'm away from that, and just didn't pay attention for a second. And the next thing I knew, Virginia Mason was going into a merger with CHI Franciscan. So that was when I began to realize just how pervasive throughout Washington this is. My background is K-12 education. I was a classroom teacher. I was a site administrator. And so switching from classrooms to this was not a huge leap for me. Dennis, would you like to tell us a little bit about why you care about this?
Sure. Dennis Barnes. We live in the Lake Forest Park area, and we have 4 adult children of childbearing age. But I think there was a gradual awareness to me, when the Swedish merger happened, I believe it was 2012 or thereabouts. I was vaguely aware and aware that there was some consternation among particularly the OBGYNs at Swedish about restrictions that they were going to face and some repercussions from that. But living as far north in King County as we are, a lot of our health services are in Snohomish County. And King County has some balance in the access of provider services, but Snohomish and North really doesn't. And so, the little revelations came to me, such as the fact that the vasectomy that I got 30 years ago at Virginia Mason would not be performed at Virginia Mason today. And that's among the things we'll be talking about. So, Carolyn?
Oh, thank you, Dennis. So I have been in Kitsap County, Bainbridge Island and Paulsbo since the early 80s. And when I got here, I became a patient of the Winslow Clinic, which at some point became Virginia Mason. And I was extremely happy with the care I got there. I've only had 2 providers, primary care doctors in 40 years or something. Really happy with my primary care doctor. But when I heard that the system was no longer going to be a secular system, and started talking to Susan about what this meant to me as a patient, and the fact that I would no longer be really just having a private conversation with my own doctor in the exam room and being able to make all the decisions that I needed, and found out that the faith-based Catholic entities would be sort of sitting in that room with me. And I had to fire my primary care doctor and say, and she really was not aware of all of the implications of what was happening. So I did find a primary care doctor I'm very happy with, but because of that and the restrictions of services, I just joined with Susan with our original effort, which was a letter writing campaign, and that has morphed into other things, which we'll talk about.
Thanks, Carolyn. So a little bit about Save Secular Healthcare Washington. We were founded in the late summer of 2020. We're dedicated to saving secular healthcare in Washington. And we began, as we have mentioned already, by opposing the Virginia Mason CHI merger. We continued working to increase patient access to all healthcare services legal in the state, regardless of the religious affiliation of the medical system providing that care. We have nothing against any religion. We respect the right of individuals to practice the faith of their choice. What we object to is religious doctrine that restricts access to safe and legal healthcare services for patients who do not subscribe to that particular faith. Everyone should have access to a full range of legal quality healthcare services, and healthcare systems must prioritize patient needs over religious doctrine.
So here's the territory for Washington State. Common Spirit is the largest nonprofit health system in the U.S. with more than 1,000 care sites in 21 states. CHI Franciscan was formed in 1996 when Franciscan Health Systems joined Catholic Health Initiatives, or CHI, based in Englewood, Colorado. Catholic Health Initiatives is one of the largest nonprofit health systems in the United States and is now part of Common Spirit. You following this? With the takeover of Virginia Mason, it was rebranded as Virginia Mason Franciscan Health. So you'll see VMFH more often. Providence Health and Services is a nonprofit Catholic healthcare system operating multiple hospitals across 8 states with headquarters in Renton. Peace Health is a not-for-profit healthcare system that owns and operates 10 hospitals, numerous clinics, and laboratories in the Western United States, including Peace Health St. Joseph in Bellingham. Currently, 17% of hospital beds in the United States are Catholic facilities, and that figure in Washington is now 49% approximately, meaning that our state is now second in the nation in the number of Catholic-controlled hospital beds in any state, trailing Alaska by a fraction of a percentage. Note that Washington also has the fewest number of practicing Catholics in the country.
So what are the ethical and religious directives, or ERDs? The ethical and religious directives define what procedures will and will not be allowed in their healthcare system. These directives forbid or severely restrict many reproductive and end-of-life healthcare services, which we'll elaborate on in a few minutes. According to an analysis of the 2018 version of the Ethical and Religious Directives, which is a written document, the study was done by Haley Pennon and Amy Chen, who are well known for their views on the topic. And they said, quote, "The ethical and religious directives present a theological basis for the Catholic healthcare ministry and govern the way healthcare is delivered in Catholic health facilities and systems, including hospitals, clinics, and managed care organizations." And I would add hospice as well to that list.
The ERDs are incorporated into medical system guidelines. This is the primary way that the Catholic Church has instilled its doctrines throughout our state and national healthcare systems. The ERDs prohibit Catholic-owned and affiliated healthcare systems from providing services that the Catholic Church deems to be either immoral or potentially scandalous. As a result, the U.S. Conference of Catholic Bishops, all men with no professional medical credentials or training, are able to create standards that dictate our healthcare.
Well, there's a misconception that ERDs refer to just to abortion or death with dignity or end of life provisions, but that's not the case. There are a variety of other procedures that are restricted or banned. Contraception, which is limited even in the cases of sexual assault. Sterilization, tubal ligation, and vasectomies that are only allowed for medical reasons, not as elective surgery. Abortion, any fetus that has a heartbeat, even to save the mother. Procedures for ectopic pregnancies and some miscarriages are considered abortions. Infertility treatments such as artificial insemination, in vitro fertilization, something that's been part of our family as well. Surrogacy, affecting both heterosexual and gay couples, hormone therapy, especially related to trans patients and transgender surgeries, end-of-life care, even death with dignity provisions under Washington law. A special note on that, ERD number 61, we'll talk about below here, references to the, quote, virtue of redemptive suffering as an alternative to ending your own life through medical aid in dying. So we'll talk a little bit about that later. There are 6 parts in the current version of the ERDs. We're going to give a brief overview of the 5 parts that are most directly impactful to patients. They are social responsibility, professional patient relationship, reproductive services, end-of-life issues, and collaborative relationships with secular providers. At this point, if there are any questions, we'll pause right here for a moment.
And I suppose those would have to go in chat. I can't see at this point if people are raising their hands or not.
Amber can, right?
Yep. Well, I don't see anybody's hand raised, but France might have a question.
No, I was just saying that Amber could read the chat.
Usually,
Well, why don't we go ahead and move on?
Okay.
Yeah.
Okay.
Okay, so we'll move on, and then if you save your questions till the end, then that'll be good.
Okay, well, thank you. So Ethical and Religious Directives Part 1 talks about social responsibility. And this social responsibility, there in this document with these different parts to it, all of the important points that are trying to be made in the document are numbered. And so the social responsibility, I just want to talk about two of the important points that are speak to the social responsibility. Number 8, the relevant requirements of canon law or religious law will be observed with regard to the foundation of a new Catholic healthcare institution, the substantial revision of the mission of an institution, and the sale, sponsorship, transfer, or closure of an existing institution, which pretty much covers in entirety what can happen in a hospital, whether it's being built, it's being sold, it's being transferred, whatever. And so the canon law will be observed in all of these institutions. And number 9, employees of a Catholic healthcare institution must respect and uphold the religious mission of the institution and adhere to these directives. And these are doctors, other professionals, people that work there, anybody who works within this institution. And we have heard of actual documents that need to be signed if one is to work in a Catholic-based hospital. So that's very concerning.
The second part that we're going to talk about is discusses the professional patient relationship. And this spends a lot of time talking about respect for patients, how physicians and patients or other employees of the healthcare system and patients interact with one another, things that will be done, things that won't be done. And there are specifically 2 directives, which is how they refer to these numbered items that Carolyn mentioned. There are 2 specific directives that get to the heart of our concerns with this particular document. And also just want to point out to you the statement on the slide before I go into what these 2 directives are. The statement taken from the narrative portion of this section makes it very clear that the relationship between the professional and the patient is deeply ingrained with Catholic identity in healthcare institutions. So the 2 ERDs I'd like to mention are 24 and 28. In 24, the statement is made, the institution will not honor an advance directive that is contrary to Catholic teaching. So while many of us think that this only refers to death with dignity or medical aid in dying, that's not the case. It can be any request that might run afoul of doctrine. For example, patients who are only being kept alive by a pacemaker becomes an issue, which many people aren't aware of. And then in Directive 28, the free and informed healthcare decision of the person or of the person's surrogate is to be followed as long as it does not contradict Catholic principles. So you can see what some of the issues are here.
So in part 4, issues of reproductive care and the beginning of life, I'll let you read this statement here, but I'll read it aloud. The church cannot approve medical practices that undermine the biological, psychological, and moral bounds on which the strength of marriage and family depends. Reproductive technologies that substitute for a marriage act are not consistent with human dignity. So the fact that religious institutions refer to all procedures that result in termination of a human pregnancy as an abortion, even when the fetus is not viable and not ending the pregnancy could lead to serious or fatal consequences to the mother, that's not accidental. This is a deliberately contentious term used to upset people. And the specific ERDs involved with this that deny these forms of care, of healthcare, are 38, 39, 40, and 41 denies acts of assisted conception, such as in vitro fertilization or artificial insemination. Number 42 denies surrogacy. Number 45 denies termination of a pregnancy at any time, including miscarriages if there is still a fetal heartbeat. Number 48 denies any intervention for an ectopic pregnancy. This is perhaps one of the most shocking examples, I think.
So the Ethical and Religious Directives Part 5 is about the other aspect of our lives, is when we are dying. And I just want to read this statement that gets the point across. We are not the owners of our lives, and hence do not have absolute power over life. We have a duty to preserve our life and to use it for the glory of God. The two directives that I specifically want to talk about, and particularly the choice of language that is really not accidental. Religious institutions refer to physician-assisted suicide, while secular institutions use less charged language, such as death with dignity. And specifically, these ethical and religious directives state, number 60 states, quote, Catholic healthcare institutions may never condone or participate in euthanasia or assisted suicide in any way. Number 61, quote, patients experiencing suffering that cannot be alleviated should be helped to appreciate the Christian understanding of redemptive suffering. And just to go into what redemptive suffering is, the Catholic belief that suffering and death can take on a positive meaning through the redemptive power of Jesus' suffering and death. This does not lessen the pain and fear for a terminal patient, but gives confidence, which allows the person to bear the suffering and pain and not be overwhelmed by it.
And then the final segment our section of the ERDs that we're going to talk about this evening addresses collaborative arrangements with other healthcare organizations and providers. And this one is very important because often you will hear officials from Virginia Mason Franciscan Health or one of the other systems saying, yes, but no, that particular provider is secular. That hospital is secular, that clinic is secular. But in reality, that doesn't mean anything when you read the directives and you see how they have been revised to take away loopholes that had at one time existed that did allow for hospitals that were brought in through a merger to behave more like a secular hospital in many cases. And the three directives that I specifically want to point out this evening are 70, 73, and 74. The language in 70 says that Catholic healthcare organizations are not permitted to engage in abortion, euthanasia, assisted suicide, and direct sterilization. Again, we've pointed out the charged language that's used here in those kinds of references, but also this directive then lays a foundation for the next two that I want to mention. 73 says that a Catholic institution must ensure that neither its administrators nor its employees will manage, carry out, assist in carrying out, make its facilities available for, or benefit from revenue generated by immoral procedures. And then 74 says, in any kind of collaboration, I want to say that again, any kind of collaboration, whether it's called religious or secular, whatever comes under the control of the Catholic institution, whether it's by acquisition, by governance, or by management. So the institution doesn't even have to be owned by the entity for this ERD, for this particular directive to apply. It must be operated in full accord with the moral teaching of the Catholic Church, including its directive.
So a question you might have is, how are the ERDs enforced? Well, local bishops, when there's a question, preside over the interpretation of the ERDs and make ultimate decisions regarding contested medical cases. This can take some time. And certainly time is not something that is a value within a critical health situation. Providers who are employees of the healthcare system or who contract to perform services within the system are required to sign contracts that include clauses in which they agree to abide by the ERDs as a condition of employment. Providers in either of these situations are fined or fired if they violate the ERDs. There may be situations where independent providers refer patients to facilities owned or operated by the healthcare system. In those cases, the ERDs are normally enforced.
So what are the impacts of the ERDs? And you can see 3 of the most important bullet points, but there are more. 1, dangerous and unnecessary delays may mean patients are unable to receive the care they need when they need it. For example, a patient who needs miscarriage management may be referred to an ethics board for a decision as to whether or not the necessary procedure can be completed, instead of being provided immediate care, or may be referred to a provider who is outside network and located many miles away. 2, this disproportionately harms women, terminally ill patients, BIPOC, that is Black, Indigenous, people of color, LGBTQ+ individuals, low income, and rural populations. And it results in reproductive injustice to individuals and communities. Number 3, Catholic healthcare systems in Washington are among the most expensive in the state. Additionally, when patients are forced to seek care outside the system, insurance may refuse to cover it or reduce coverage significantly. Additionally, patients may be liable for travel costs to get to providers who will treat them. And if you're privileged, you may be able to travel to another provider in a distant city. That might take you hours, but if you have problems with traveling, then that is an issue. That is definitely an issue itself. So this really impacts certain members of our community more than others, but it really, in effect, impacts all of us.
So what can we do about this? There are actually 4 ways that you can engage immediately to start taking steps that will help rectify our current situation. And they're listed here on the slide. We're going to take just a few minutes to look at each one of these bullet points and elaborate a little bit on the kinds of things that you can do.
There were about a dozen bills regarding the healthcare that we supported in the 2022 Washington legislative session, most of which did not survive the short session. Chief among those was the Keep Our Care Act, which would have provided a process for public comment and review by the Attorney General's office to ensure that any mergers of healthcare service organizations did not adversely affect the range of services, their costs, or their quality. The Keep Our Care Act was supported by a broad coalition of organizations that included the League, and we thank you for that support, for those of you who are part of the League of Women Voters. This bill and all of the others that did not advance will likely return this year. At the national level, President Biden's healthcare platform does include regulation of mega healthcare systems across the country, and the appointment of Lena Khan as the chair of the Federal Trade Commission are both positive signs that there is interest in addressing this situation federally as well.
And you can advocate for yourself and others. I think all too often people make assumptions about the care that they will receive and discover too late that their assumptions are wrong. So on the screen, you can see some questions that you might need to ask, or you need to be aware of when you are having medical care. And it's being provided by a healthcare system that's not secular. And some of the things are, who owns it and operates the practice? What services do these providers offer? And a couple other questions, but you need to really listen between the lines, because the answers may not be transparent or forthcoming.
And just to add to what Carolyn said, also it's important to understand that in the mergers between Providence and Swedish, and now Virginia Mason and CHI Franciscan, an enormous amount of money exchanged hands so that the faith-based provider could continue to use the secular well-known name. It's only this past year that Swedish and Providence have finally been very open and publicly combined the name to be Providence Swedish. And Virginia Mason Franciscan Health was conceived of so that people would keep that Virginia Mason connection in mind as well. So there are lots and lots of ways that roadblocks are thrown up to keep you from recognizing what's actually going on. Now, we also have available for you, and I will put the link to this in chat when we finish, when we wrap up in just a few minutes. But we have available to you a live binder, which is in effect a digital 3-ring notebook. And if you look at this slide here, you'll see that there are blue tabs that run across the top. Those are the equivalent of dividers in a traditional notebook. And I'm going to go ahead and click on this to open it so that you can see when you go into the live binder, when you open it, you'll first come to a table of contents. But then if you want, for example, to look at advocacy organizations that are concerned about this work, you can click on that tab and you'll come to a page that then has what are called subtabs or digital pieces of notebook paper. And you'll see here that we've got links to ACLU of Washington, to a variety of other organizations, the Ethical and Religious Directives. If you are interested in learning more about those and perhaps even reading the document that we were talking about this evening, you can click on the tab called Ethical and Religious Directives. And right here, the very first thing that is listed is a link to the PDF of the most current version of the ERDs. Then there is also something that's really interesting. It's a comparison between the 5th and the 6th versions of the ERDs. The 6th version is what we've been talking about this evening. It was developed in 2018 to close all the loopholes that had been exercised in the past to allow institutions to ignore, basically, some of the ERDs. So I won't spend any more time with this now, but as I said, I'll go ahead and stick the link into chat as soon as we're done here, and that will give you an opportunity to look at it at your leisure. We update it all the time, and it's a really good resource for people who are trying to figure out more about what's happening in this area of concern.
So Susan, could you answer a question?
I sure could.
So when you click on a tab, you come up with a bunch of subtabs or digital pieces of paper that are color coded. What does the color code refer to?
Okay, the color code is simply an indicator that, for example, if you see a bunch of red tabs and a bunch of blue ones and a bunch of green ones, those are simply an indication that the red tabs are all related by topic in some way, shape, or form. They go together. The blue ones all go together. The green ones all go together. So it's just a little way of helping you kind of see what supports different resources that support each other.
Thank you.
You bet. Okay, so
get angry. Refuse to accept this as an unrepairable situation. We know it will happen if we do nothing. So let's fight back. We're working to educate the public about the impact of mega healthcare systems on our access to care, how to work with legislators to enact laws that will protect us, and how to help Washingtonians know how to advocate for themselves.